Hey guys, just a brief background. Dr. Malcolm Kendrick brought out a rather provocative blog post in January, and I chatted to him afterwards, and we agreed it'd be a great idea to get with Dr. Scott Murray, cardiologist, and thrash the issue out in kind of a friendly debate or discussion. So I think you'll get a lot of useful information here which really clarifies the issue. And watch out for the Kickstarter campaign for Extra Time, a new movie from Donal O'Neill of serial killers, and it will follow people who have gotten their scan results and taken action to prevent that future heart attack.
So if you want to know what your risk is for heart disease, have a coronary calcium score.
Here we are with Dr. Malcolm Kendrick and Dr. Scott Murray, cardiologist, and we're going to get into the nitty-gritty of coronary artery calcification scanning, CAC. Should one get one or not? And I think we agreed, guys, that we're going to start off today with one of the questions we didn't get to before, and it's around whether a randomized control trial is needed to prove that a high-score, high-risk patient getting the score and then actions are taking, that the actions will actually lead to better outcomes. And that RCT question will also tie in with screening in general. How effective is screening, and has it always been proven to be effective in getting actual outcomes improved, or is it a paper tiger? So I think, Malcolm, if you could kick off first with your thoughts on screening and the need for potentially an RCT or randomized control trial.
Thanks. Yeah, I think this is where it kind of is where my concerns lie, if you like, about it. I think that the CAC screening is very good at identifying people at risk, much better than any other mechanisms that we have, blood tests, etc., etc. But I've looked at screening a lot of times. I've studied it, I've analysed it, I've even read books on it, and but I've seen that a lot of interventions that people have thought are going to be good, not just screening. I think we talked about this earlier. Ivor was one of the very first interventions in cardiovascular medicine was after having a heart attack. The first ever Herrick identified the first ever non-fatal MI in 1913, and then immediately said, and what you should do is 6 weeks of strict bed rest. The patient should lie in bed, not move a muscle, and should, if they need a poo, they have a poo in bed. If they need a pee, they have a pee in bed. They lie flat. They can't even sit up at the end of the bed. This was standard medical treatment following a heart attack until 1960s. So it went on for 50 years. There's no evidence whatsoever that this was a good thing to do, but it sounded like a good thing to do. You've had a heart attack, your muscle's been damaged, you must rest it. 6 weeks, that's the sort of time it takes for a bone to heal, so probably about the time it takes for a heart to heal. Now, I did a vague analysis of this, and at one point reckoned it wiped out millions and millions of people. Lying flat in bed for 6 weeks, you're almost bound to get a DVT. That goes to your lungs, you die of a pulmonary embolus. Also, your heart muscle degenerates very rapidly. It was only in the 1960s when they actually did the astronaut trials, they found putting fit young 18-year-olds in bed for 6 weeks just to see what would happen if nobody moved for 6 weeks was damaging their hearts. Suddenly, no more did we have strict bed rest. And in fact, one chap who looked at this, Bernard Lowen, in the 1950s, said, I really don't think people should be lying in bed. He tried to sit them up at the end of their bed, and other doctors got medical students to come through his ward with coffins on their shoulders with the word murderer on the side. So certain were they, this was really absolutely the thing that should be done. And Bernard Lowen in the 60s, when coronary artery bypass grafting came in, and he was worried, he was concerned that people were getting angiograms, they were showing a blockage in the left anterior descending, and they were calling it a widowmaker, which is where this comes from, the whole widowmaker thing. And then they were being said, well, would you like us to do something about your widowmaker, or would you like us to leave it alone? And of course, everyone had the operation. So the immediate activity was people went straight into it. He was finding people who had angiograms. The angiograms were causing them harm, and he tried to do a clinical study. At the end of his clinical study, which he did manage to do, which took him 4 years to even get published, he showed that in many cases, just using standard medical treatment was as effective as having a coronary artery bypass graft. This is in the non-acute situation. So I've seen examples going on, and you said we discussed screening. You know, the first ever screening program was with chest X-rays to find out if people had lung cancer. They had to abandon this very quickly because, first of all, they saw all sorts of things that didn't know what they were, and then by the time they actually were able to see a cancer, it was too late to do anything. So that had very, very poor outcomes. So we see the weaknesses of screening, the weaknesses of scanning. There was a study in the BMJ showing that all the cardiovascular risk factor study analysis and intervention programs studied over the last 50 years, the net effect had been 0.00. It was so perfectly around a 1, as I say, as an odds ratio, that actually the confidence intervals were 0.98 to 1.02, which may not mean anything to most people. It just means really absolutely no effect. So I'm always concerned that when you start doing screening and you start scanning people, that you must do the next thing, which is to show that it really, really works. Because if you don't do that, people like me are always going to say, I know it all sounds like it makes sense. I know everything sounds like it makes sense. But to quote one of the Huxleys, I don't think it was Aldous Huxley, the tragedy of science is the slaying of a beautiful hypothesis by an ugly fact. And unless you do the RCT examination, you might think you've got everything sorted out. And then the final problem, I think, is that, yes, you can show somebody they're at risk because they've got they've got a high calcium score in their arteries. But unfortunately, I also feel is you're then sending them off into a world where potentially they might be told, I think it was your comment, yeah, they'll all be put on a low-fat diet and a statin and turn into vegans. And really, this is probably not going to give them any benefit. So that's me trying to summarize my concerns, I think, and attack me at your will.
Well, yeah, Malcolm, and in fairness, so if you parse that out, we've got kind of poor screening programs in the past, and I know mammograms is another. There are many examples where actually they presumed by finding cancers supposedly early that they would do treatments more early and that they would get better outcomes. And it didn't quite pan out so much because there was over-diagnosis, over-intervention. So there's various screening programs where assumptions were made and they weren't good. And then on the bad interventions, yeah, I mean, the sleeping one is a classic example, or not sleeping, but the lying down and resting. And we've got lots of other examples as well. I guess for me, what's really different though is that the RCT, I don't think would ever be required for the calcium scanning because the specificity and the sensitivity is so strong, and we know there's an enormous relationship with risk, right? So we know it will identify the at-risk people. So there's no question about that. That's locked in. Now, the second deductive or inductive step is to say that we can go in when we have the at-risk patient and we can help slow their progression or change their outcome. So it's not really like, you know, A causes B and B causes C, therefore A causes C, and all these logical mistakes that were made in the past. This is pretty bulletproof. For me, the whole question is, when you identify a high-scoring person who the day before thought they were low risk and was sleepwalking along, can you go in and actually help resolve that progressive modern chronic disease and take away their risk?
Yes,
now,
I think that's what I mean by outcomes, is that is the outcome, is the reduction, the actual real reduction in risk. They did an analysis of the American CV risk score, where they went back through the records and then said, well, how accurately did this predict what actually happened? And what they found was the prediction was rubbish. I think that's not true with CAC scanning. But the question then is, well, if you find you're at high risk, are the things that we then do for you beneficial? Will it like finding breast cancer and then taking it out, but finding that it then reappears one day later somewhere else, and you've actually achieved nothing? So can you then stop it going forward for sure in sufficient number of people that you're doing an overall benefit study? That's the outcome study.
That's the outcome. The outcome is demonstrating that you can take positive action based on finding out the risk. So we acknowledge that the calcium scan will tell you the risk to an incredible degree. It does that bit perfectly. The question is, can we actually fix the problem then? Now, I think cancer is a poor example in some ways, because I don't want to get into the cancer discussion, but the reality is, you know, there has not been a whole lot of progress as much as was expected in the last 40 years. So it might be a case where you can't change the outcome as much as you'd like. For me, the difference with heart disease is we now have people all over the world, hundreds of emails I've got, with people slowing and stopping the progression a year and a half apart. We know from Raji that the risk collapses in that case, and it makes all the mechanistic sense. If the progression is slowed down and stopped, then the risk will collapse, and the calcium, even for a high score, will just remain as a leftover scar of a prior progressive disease. So I think we feel with magnesium, with K2, with low carb diets, glucometers, with people actually taking action, the correct action, there's no question but that we'd make a massive difference to certain people's outcomes. But the problem or the sticking point is, I think with yourself, Malcolm, is the generic orthodox interventions. If they're applied, you're not going to see so much difference, you know, for people who are identified.
Well, no, that is absolutely it's the fundamental question of that outcome. I mean, that's what we haven't, you haven't, or we haven't, one hasn't got the clinical trial evidence that you'd have to randomize people, you do a scan, you get 500 people and 500, or however many people you feel you need.
You need 30,000 in each arm. That's the problem.
Well, hopefully, if you think your intervention is going to be more beneficial, you need less people. People always say to me, well, the study was too small to show a major effect. I said, no, the study was too large to show an effect. You have to have 10,000 people in either arm. The effect you're studying must be so small, it's almost not worthwhile. If you could do a study on 500 people and get statistical significance, now you really have something that was important.
Yeah, I think the problem is the actual amount of events that you're likely to see with the modern treatment of coronary artery disease. I mean, there was the MASS trial, which was trying to show the benefit of abdominal aortic aneurysm screening, and they needed 60,000 patients. And the studies, the RCTs that have been done in this area have been relatively small. Like there was Eisner, which was about 2,500 people randomized, and all that they showed was that if you put them through a calcium scan or not, that you don't increase downstream testing, that you don't increase cost over and above the no scan. So that sort of was a randomized trial in 2011 that showed, or sort of tried to help with that aspect of the concern that you're doing the wrong thing and you're going to be spending lots of cash. There have been a few other randomized controlled trials in this area, but again, all suffering because the actual rate of coronary events at the end of the day was, you know, in the calcium score, 0 people, less than 1%, and the other people somewhere between 2%. So in order to have the correct power to detect a statistically significant difference at the end, you're going to need at least 30,000 patients, and you're going to need to follow them up for more than 5 years at least, because there was another randomized controlled trial called Factor 64, which used CTCA or no CTCA in patients, and they showed that after 5 years that the curves had diverged for future cardiovascular MACE. So I think that you're looking at having to fund a big trial which follows people up for a long time to really prove what you need, Malcolm, in order to sort of get that point across.
And is it not the case, though, Scott or Malcolm? To be honest, this whole RCT thing to me is almost, it's a distraction, well, to an engineering mind. And Professor Harvey Hecht wrote about this in a paper called The Deadly Double Standard. And he made the point that we need the best methods to identify the patients at risk. And obviously then we have to do the best interventions. But he said that this requirement for proving outcome has not been applied to any previous technology like the stress test or the Framingham. So all the weaker ways of identifying the vulnerable at-risk people all got a pass. And then the best one, which at least fulfills your first thing, Malcolm, that you actually do identify the right people, that one is being held to a much higher standard. And the reality is that really for me it all comes down to, are we confident that we can intervene with someone and greatly reduce their risk once they're identified? And an RCT, if one is done, even Scott, as you say, if you do 30,000 people in each arm, so you get enough high scorers, so you can see enough people where there's a reduction in events like the previous RCTs were beginning to point towards, they're only going to do generic interventions like statin or whatever, some blood pressure meds. So for me, the much more important thing is, by kind of a million miles, is that the world emerges in the coming 10 years to acknowledge everything in your blog, Malcolm, everything I say about root causes, or you do, Scott, or the EuroAspire study where we know that 76% or much more of cardiac victims across Europe are essentially diabetic, and we know we can fix that. You know, the non-orthodox fixes for this modern chronic progressive disease. It's a disease of modernity, essentially. We talked about the Maasai before. They didn't have calcification. They didn't have events. The semaine. We know it's a modern chronic disease driven by environmental factors. We largely know what they are. And just because orthodox medicine ignores them, does that mean that people can't have the technology to identify they're at risk and to search, take responsibility, and discover what the real causes are?
I think you're conjoining a couple of things together that actually don't fit. But the problem is, you're up against conventional thinking. Conventional thinking says RCT. Now, you don't have to do randomization in the way that is the standard. You can use what they call a Bayesian approach, which is that you can use each person that comes through as a study in and of itself. And I think you can also now use historical record, A, for the patient, and B, for what we know the general outcomes for these are. We should have enough data on this to say that we know that the scoring of calcium scoring is accurate enough that we know what's going to happen to people over a 5-year period. So to an extent, we have our comparator group. Now, I know a lot of people won't accept that in the conventional world, but I do. And you're right. You know, antibiotics were never subjected to randomized controlled studies. In fact, I worked with the European Society of Cardiology at one point, set up an educational website for them at one point. And we discovered that around about 86% of interventions were not based on any evidence whatsoever. So yes, to an extent, it's like one rule for one lot, one rule for another. And the other thing is, we're trapped in a paradigm whereby if you don't do a 10,000, 10,000, 20,000, 20,000 RCT, people go, well, you haven't proved it. And the only people that can realistically afford to do such studies are pharmaceutical companies with hundreds of millions of pounds. Your average person that cannot get the resources required to do this. Equally, if you suggest that some of the conventional interventions are not valuable, ethically, you're not going to be allowed to carry out your study because you're going to be told you must, you know, do X, Y, Z. So the problems are extremely big. There's no question on that. But I think you could do a kind of, you could still get the data on enough people using it as we have the historical evidence and patients as their own control, if you like, and use a Bayesian analysis so that every single person that comes through can be added to the database. I think that you could go along that line, if you like. I don't know if you agree with that.
I mean, I think, you know, I know for a fact that Scott Hart 2 trial is about to start, and I'd give a shout out to Mohammed Mia, who's a former trainee of mine, and Professor David Newby in Edinburgh, because David Newby run the Scott Hart trial, which was an open label parallel group randomisation of patients coming to a random chest pain clinic in Scotland. And they got either no CT scan or a CT scan, and there was 2,000 odd patients in it. And after, you know, sort of 4 years of the data, they found that by seeing the disease, by showing the people their disease, by starting guideline-based interventions, which you may agree with or not agree with, they were seeing curves diverge after 3 months for event curves. And that was put down as being the patients actually grasping what had happened with the follow-up and having guideline-based treatment. That's what it was put down to. They said, well, you know, statins and aspirin in people who had a certain level of disease was improving that. So I think you've got to take that. And I know that Scott Hart 2 is coming, which is going to be, again, randomised, but will be people who are asymptomatic. and they're going to show them whether they've got disease or not again, and follow them up in terms of the behaviour transformation. Now, we know from previous randomised controlled trials in this area that if you show people their disease, that the risk scores, whatever you want to say they're rubbish, you can show a statistical improvement in the risk scores. You can show a statistical improvement in the cholesterols, the triglycerides, the diabetic control. There was a recent randomised controlled trial in the Lancet called VISA, which was quite a big one looking at carotid plaque, and they showed people a very simple diagram of the carotid plaque. And again, they showed that they can improve patients' adherence to medication, to lifestyle. So I think it's important, because if we're going to burrow down into what constitutes this test being appropriate, then it boils down to prognostic efficiency, which I think you can say is great for calcium scanning because it's very predictive, and it gives you incremental prognostic information above and beyond the standard crappy Framingham risk scores, JVSD, whatever, give you a bit of a sniff. But the big question is, does it give you therapeutic efficiency, which is what Malcolm's talking about in terms of reducing adverse events? And I think we can get to that point now, because we know from Raji and Heinz Nixdorf and these other trials showing we can reduce the risk factors that cause atherosclerosis in the first place. We could probably stall the scores, we can reduce the outcomes, and it's incrementally cost efficient. We know from Eisner, randomized controlled trial, that you don't spend more money after a CAC score. And that is across the board, because if you're the 50% who are CAC 0, you get your medication stopped, you get no more testing, or you shouldn't get any more tests, so you don't get any more costs. If your CAC score more than 400, then you might spend more, something like 9,000, instead of the people who didn't get a scan at all being about 3,500. But that's only 8% of the population who will have that score. And you could say that those costs are justified because they've got significant disease. And we need to look into that more. Now, I take the point that they shouldn't be in a cath lab getting a stent, but they should certainly be getting ischemia ruled out, and they should certainly be getting the right information. So I think between the three of us, I think we can come to an agreement that, yes, it is the right time to go forward with this. We have randomized controlled data, we have prognostic efficiency and therapeutic efficiency, and we should just start making more of this. That's my thought. I'd love to agree with you, Malcolm, but then the both of us would be wrong.
Well,
you know, the change in, when you're doing scanning and screening and intervention, sometimes you're moving things, you're never getting black and white, you're moving things in certain directions. I was just saying to Ivor, at my little calculation, at £400 a CAC scan, 30 million adults in the UK, that's 12 billion quid. So, but the other alternative is if you can rule out a number of people and say, well, actually, these 92% of people we don't need to do anything for, then that is a major benefit in and of itself, clearly. And I think that, you know, we're not. I mean, we're discussing this, and we're not arguing with each other. We're passing comments, and I think that the reality is, when it comes down to it, my concern is, are people going to get the CAC scan and then go off and be told to do things that I would consider it's not going to do them any good by the conventional medical world? Yeah. And that is the thing that is what I'm concerned about, if you like, majorly, is because then your outcomes are just not going to be any better necessarily. Although you're saying that from the Scott Hart study?
Scott Hart study, yeah.
That you can show that even using conventional guidelines and paradigms, that you can get benefit, which then is a good thing. And then I suppose you've got to balance that off against what else you could do with the money, I suppose. But anyway, Ivor, sorry, you were there.
So yeah, on the point, Malcolm, about screening, you know, if you just screened everyone, that would add up to a lot of money. Now, you could argue that 45% of people currently on the statin roll will get zeros and they can go off. And I suppose it's important to remember, CAC has been rejected by the orthodoxy for a reason. So I always thought it's my enemy's enemy is my friend. They rejected it for a reason, because they knew that more people to be taken off drugs and interventions than would be put on. And we've seen the number needed to treat in some studies with a zero score is like 500 or infinite. In other words, a zero they shouldn't get anything. And then you see sometimes numbers needed to treat as low as 20 or 30 in very high scorers. So you can actually put the statins where they do some good. But I don't think CAC, though, we're talking about mass screening, to your point about the 12 billion. For me, or certainly my whole ethos around this is, it's for people that everyone knows about the scan, knows there's a test that can give them a 20x, you know, risk multiplier, high versus low, and they know they can go in and find out if they have a problem and then take the responsibility to deal with it. So I always think of it as something we need to get the message out on for people to choose, to put the power back in the patient's hands. So the whole argument about mass screening, I almost don't get into that too much. Yeah, Scott says, if they do a lot of screening and the orthodoxy actually starts doing it, there's benefits as well, like taking people off meds and all that stuff. But I'm not thinking so much about that. I'm thinking about more the personal question, like in your blog, for instance. Should you get a scan? You, the individual, should you get a scan? So maybe we could talk about that question. Should you get a scan? And does it depend on the type of individual you are?
Yeah, well, I think, sorry, jumping in, I think that, I mean, I've had enough emails from people who've had a high CAC score who it's turned them a bit into obsessively worried about their health and anxious and worried and then wondering what to do. And I think some people, like, as I said, Ivor, you're both Irish and an engineer, so you don't give a damn about anything. Not everyone is like that.
I'll take that as a compliment, Malcolm. Yeah. But you know, it's a great point, because those people who are worried, is the discussion then that they are people who really ought not to have got a test in the first place? Because were they people who just went hoping for a 0, and then when they didn't get one, when they knew that the whole point of the scan is it would tell you the truth, why did they get one if when it does its job and tells them they've got a problem to manage and deal with, that they then get wound up? Do people need to be counseled before they go? Is it really at that level?
I think I'll let Scott talk, because he's done a lot more scanning than I've done and dealt with a lot more people, although I get the kind of fallout from it. But it is this thing of, I have said to people in surgery, you know, if I'm doing this test, we may be looking for cancer. If you've got cancer, do you want to know? And if they say no, I say, well, I'm not doing the test then. Now, I know that's considered an extremely outrageous statement, but I say, I'm not going to, you know, there's some people say, oh, well, if I got cancer, I don't want to do anything about it. There are people like this. So there's no point in going, oh, no, that's the most extreme end of it. But if someone says, well, if it scores 3,000, do you want to do anything about it? Well, I'm not going to change my lifestyle. Well, then don't have the scan.
Yeah.
And that's obviously sitting at one extreme, and not everyone's there, but these people do exist.
This comes back round to what we talked about at the start with the life stage segmentation model. Like, I mean, I don't know where you sit on it, but as I said, I'm probably a balanced compensator with a bit of healthy realism. But the majority of punters out there are unconfident fatalists, live for tomorrows, hedonistic immortals, DIY health deniers. So they all just got their own little way that they see health. And it's not until it's there that there's a problem that you can change them out of that paradigm. And some people can't change because they don't have the literacy or the ability to become a fighter or a thriver, to move themselves from being a unconfident fatalist to suddenly becoming a health conscious realist. It just doesn't happen. And I think ultimately you're going to potentially see a lot of health conscious realists and maybe some balanced compensators coming for a scan because they want to know and they want to be able to take action or, you know, find for themselves a way forward with help. But you've got a whole other swathe, possibly even 50% of the population, who don't want to know. If they did know, probably wouldn't want to take action, or if they did know, they would just be exceptionally anxious and worried, and it would probably make them worse. So I think it is about, Malcolm has a point about teasing out what that potential person wants and where they kind of are in their worldview of their health.
Yeah.
So yeah, I think that's really important.
So to that, Scott, and I guess we always knew that was the case, and I may take it for granted, or as Malcolm says, I'm Irish and all the rest, I'm an engineer. But the thing is, the people who are getting the information on the scan, if they understand what it is, and when I give talks on it, I show these enormous risk multipliers. I mean, I actually kind of emphasize how scary it is in order to get the message across. So people know, wow, I could go in there and get a huge score. So who will go in, who should not go in? I mean, the people you're talking about who'll only get worried, or the people who are not going to take action anyway, they're not really people who we're targeting, like people to give them the knowledge to take control of their own health. We're worried about the people who'll drop dead at 55 with 3 kids who had no idea they had a disease. The first they found out, they were dead. And they'd like to go back in time and have an opportunity to at least find out, should they wish to, and take action. Is that not what it's all about? Like actually giving people a chance to save their own life, should they choose to take it?
I agree with that. Well, first of all, you've got to demonstrate you definitely can save their life, which is.
Malcolm, honestly, you know from your blog, we know the causes.
And then the other issue. I mean, it is this. I was unaware of these classifications of people coming in. I like them actually. I'm going to use this in future.
Yeah, send you
the thing, because I do see this with people, and I suppose when someone's saying a screening test, I'm thinking screening test, that means everybody.
Yeah.
A modified screening test for people who would be motivated to do the right things. Then we're getting rid of a lot of the concerns I have, which is you're going to worry people who are then just going to go off and fatalistically go down the pub and drink themselves to death, and that's an extreme. But that you can see this happening with some people. So I think, yes, I would say that if screening can be, if we can work out a way of ensuring that almost a bit of pre-counselling. If we find this, do this. If we find this, do this, and etc. That would be an extreme. That would change the benefit to harm ratio around in a significant way. That's absolutely true. So
I'll give you a story on this one because I want to try and make it a bit sort of more upbeat. There was a guy who came to see me who was 37, and the only reason he came was he had an argument with his ex-partner on the phone and felt a bit of a twinge in the centre of his chest, and his dad died of an MI at the age of 50. So that's why he came to my clinic. I said, you're going in the scanner and we'll do an echo. And to be fair, his ECG didn't look completely normal. He went in the scanner at age 37 and got a 2000 score, calcium score of 2000 in all 3 vessels, including the left main. And later that day, in fact, the next day, we admitted him. He went to the cath lab and we found that he had a blocked distal left main into his LED, and everything was shot down and he was running on sluggish flow, and actually his anterior wall was starting to become hypokinetic. So the main front wall of his pumping chamber was going down the tubes. He then immediately went across for an inpatient coronary artery bypass graft, and he had a 6-way bypass done, and he now plays 5-a-side football every week, and he's much healthier. He doesn't obviously get any, he never ever had an MI, so his anterior wall was hibernating, so now his left ventricular function is completely normal and he's completely replumbed. Now I put it to you that guy didn't have much longer left on collaterals. He might have collateralized everything and lived roughly to the same age as his father, maybe even less, given how bad his coronaries were. But he was a bit of a drinker, bit of a smoker, doesn't do that now, obviously completely seen the error of his ways, and obviously that familial thing was just lying there, waiting to pounce on him. So I've got multiple examples of that, and I think that when you say that intervention is possibly not the right thing to do and leave people alone and don't do those things, I think it's really important that people know that intervention can do amazing things for people in the right circumstances. It's just making sure that someone doesn't get a calcium score and ends up in a cath lab getting a stent, without going through the proper channels and the right information. So I can see it from both sides of the fence here, but there are so many stories to tell that I could bore you.
Oh, no. Well, absolutely. I mean, I'm not, the trouble is when you get stories like this and then you get people who say, I mean, when they get screened and it was picked up and they said, oh, thank God it was picked up. But I do get contrary stories, and you do get contrary stories the other way around. I don't want to end on a negative note or anything. I think the important thing, I think, from this discussion is I hope that if anyone listens into it, that they can take some of the concerns maybe they hadn't understood before, some of the things you've said that are the benefits they hadn't thought before, and I think some of the hopefully can go and discuss things with their own health provider in a more knowledgeable way, which is what it's all about in the end, isn't it? It doesn't, to an extent, it doesn't really matter what I think. I can say to people what I think. You can say to people what you think. What matters is you're getting a balanced view from different people, and then they can come to their own decisions. Speaking personally, a great screening test is one. It's got good sensitivity and specificity, and at the end of it, you can intervene based on those results and definitely show the outcomes are positive. I think that there are positive outcomes, that you've seen your own positive outcomes. There can be negative outcomes. There's cost issues. There's all sorts of issues of the wrong people getting scanned. But I think hopefully from this, it's opened up the thinking in people's minds a little more, and hopefully I hope that by challenging you guys a bit, that it strengthens your thinking and your arguments as well, because that's how these things work. I'm not here to destroy coronary artery screening as a concept. I want to, if it's going to happen, I want it to be as good as it possibly can, and that it does, and any of the potential harms are reduced down as much as it possibly can. Because I don't criticize things I don't care about. I criticize things that I want to get better. Is my kind of philosophy on things. If I didn't care about coronary artery screening, I wouldn't have done a blog, and I wouldn't care. But
I mean,
sorry.
Ultimately, it could mean that we need to think about a clinic in the future that is set up that basically deals with these issues about positive coronary calcium scores, and so that we can make something that is a cutting edge, that is trying to do the best, and obviously that's how you potentially do research, but that's a whole other bureaucratic sort of wasteland is research in the UK. I mean, it's just taken my PhD fellow 3 years to get over the line and recruit his first patient, with the amount of bureaucracy in a randomized clinical trial he's doing. So it's just I think your point's made, Malcolm, that we need to make sure that people who have a positive get the right information going forward. But I don't think that should take away from the fact that they shouldn't get the scan.
Yeah, and that's fair enough, Scott. And I see both your points there, and absolutely, Malcolm. I mean, misuse of any technology, and in a sense, giving a very poor intervention that doesn't really change much, and not treating a screening type phenomenon properly, that's just bad, and there's always going to be bad in medicine. Scott, you're focusing kind of primarily there when you're talking about the actual interventions of a medical nature, and we don't want stents and we don't want useless stents. We want proper interventions as you described. I suppose
I would say you potentially do want a stent, or you do want revascularization if you've got severe ischemia and really bad coronaries that ain't going to last you much longer.
For sure, Scott, but I meant there was you don't want the unnecessary stents as per the Widowmaker movie, that are just
you don't want someone
absolutely
banging a stent into a 30% lesion that they think looks bad on an angiogram. You don't want that. You need an FFR, you need the whole shooting match to prove that it's going to be something worth doing.
Exactly. I mean, that's basically just plumbing, and it's misguided plumbing. So we all know the problems with some of the business, but you're talking about getting proper medical interventions, surgical interventions and all that, and that's fine. Calcium scan can deliver an enormous amount of life saving when that happens. But again, I just say, as we come to a close, for me, it's not even so much about the medical intervention. It's about all the people I'm seeing out there who are dropping their glucose, dropping their A1C, who are all over what they eat. I mean, if we think about it, a modern chronic disease of cardiovascular disease, and there's lots more, Weston Price in the 1920s said sugar, refined carbs, and vegetable fats. In the 70s, Mann et al., the same trio, and they didn't know about Weston Price. What's the top of our pyramid of cause? Sugar, refined carb, vegetable oils, processed foods. And then you add in a series of other mineral and vitamin deficiencies, or, you know, toxic stuff from the environment. You've largely got what's driving the progression of vascular disease, broadly. So when you find out you have big disease, you can intervene yourself and probably do way more to stop your heart attack than even the medical system can offer. Is that a sense of a hope that we could get there in the coming years, that everyone becomes aware?
Yeah, because it's a pan-vascular process in the coronary arteries, as we talked about before. And if you start settling down all those inflamed plaques by, you know, knocking, or as I say, getting all your ducks in a row, and making everything as best as you possibly can do, then all you're left with is the other underlying stuff that Malcolm talks about in his blogs, the stuff that is under the radar, that isn't your conventional risk factor bingo. We know from Interheart that 90% of cardiovascular disease is preventable anyway when you look across 9 different basic risk factors. So I think that, you know, even just doing it on that scale should provide a massive amount of preventative benefit to, you know, people once they wake up and they realise that this is something that they can own and they can do quite simply. That's where we're at, I think, now.
Maybe out of a job, Scott.
Well, that's fine. That's fine.
You have nothing to do. At least,
no, I mean, just do research into CAC then.
Won't be any CAC. No, I think that you know, yes, we need to. What we're dancing around a little bit, because we don't want to sound too controversial, is a lot of the conventional thinking here is off beam, which is another of my major concerns. Is the average person getting a scan is not going to be seen by someone who's thought about it as intensively as yourself, Ivor, or yourself, Scott, and is doing these things what I would consider to be doing the right things right. The problem, we're pinging them off into a system which, in my opinion, is likely to do as much harm to people as good in many cases, and that's really where my major concerns lie, I suppose, is we're firing people off anxious to do something, and which your comment will be turned into sort of vegans thinking that's going to help.
Or they fall into the jaws of a greedy interventionalist who just wants to throw in 6 unnecessary stents. But for sure, Malcolm, I mean, this is a problem. Just to give an anecdote like yours, Scott, from the other side, I have a 29-year-old in America. Father died at 39, massive MI, and they said he's not having a calcium scan, but he felt he lived a pretty rough life and he wanted to get one. And eventually he got one, and it was 600. And his bloods, for a 29-year-old. But that guy is all over it after that. And I mean, we corresponded a lot. There's no medical advice from me. I just go through the science. I send the talks with all the root causes. And came back to me later, his blood glucose right down. You know, his ratios were beautiful looking. So, you know, that for me is the big thing, that people who want to take ownership find out they've got a problem, and then they actually take the action. And maybe as we wrap up though, Malcolm, and I agree with a lot of what you said, the orthodox medical system is a long way to go. And I think we need to break out of it a little and go straight to the people, like you kind of are anyway, and I am. But how long do you think it'll be before a large proportion of Western people, let's say, are pretty well aware that glycemia, the sugar, refined carb, vegetable oil, it's not the fat, it's not vegan. How long do you think it'll be with the freedom of the internet before a large proportion of people will know broadly what the root causes are and how to do a targeted program to resolve?
It's a difficult question to answer because I've seen the history of medicine, and stupid ideas have carried on for an awfully long time. Interestingly, I think the American Diabetes Association, the new chairman and or person in charge of it, person, whatever that term they use for them, has recently come out and said that that she's gone on to basically a low carb, high fat diet and has lost weight, and her diabetes is now under control. We have the chairman or president, whatever it is that she is, of the ADA is now saying this. We have the work done by David Unwin, who I know well, who I used to go to talks with, and his job is to say you should cut out the carbohydrates, and then everyone would say, oh my God, if I eat fat, I'm going to die of heart disease. My job was to say, don't be so stupid. There's no evidence for that whatsoever. Don't worry about it. And I think that we are seeing, when these things change, they will change like that. There will be no sort of gradual change. Suddenly, everybody in the American Diabetes Association and all these people who've been telling people to eat carbohydrates and avoid fat will suddenly say, I never said that. It's the world will move in very fast. Where's a tipping point? Tipping points happen unexpectedly quickly, and at times you don't expect them. I feel, and maybe that's just hope, that we're reaching that tipping point. We are closing in on it, and when it changes, it will be just sudden and overnight. And I think within the next 2 to 3 years, at some point, could be tomorrow, could be 3 years' time, this will be changed. Now that may be unnaturally optimistic, but I've tried to look at the signs, if you like some ancient sort of Inuit guide that can tell the spring is coming. I see the signs of the spring and the summer coming. Now I might be completely wrong, and it might be there's a big backlash from the likes of Willett and Hugh and all that from Harvard, and supported entirely by gigantic pharmaceutical company money plus the food industry money. But I do think it's changing. So I think it's going to change.
Yeah, and I agree, Malcolm. I think it's really beginning to move now. And another great thing with regard to the scan, in a study with 20 human trials with LDL and calcium scan results in them, there was no correlation across all 20. So I think the calcium scan is going to have another benefit. We're going to see super high LDL people with 0 scores. We're going to see people with low LDL with massive scores.
Yeah, I've already seen that. Yeah.
Yeah, I'm hearing it all the time.
Yeah.
People are coming back. It's
my favorite case is a guy wrote to me in the States, 72 years old. Average LDL level for the last 30 years, 18.5. No discernible cardiovascular disease in any artery in his body. I didn't believe it. Well, I wasn't sure I believed him because people write to me with certain stuff, but actually he turned into being a case history. And so I said, oh, well, that is true then. So, I mean, yes, that would be a lovely thing to happen as well.
And saving people from statins where they're unnecessary, because we're going to get a ton of people off them, high LDL and medium LDL, just because we actually take the trouble to look to see if they have disease or not instead of guessing. So yeah, all to play for, I think. Well, anyway, any wrap-up comments from the paria, as we say in Ireland?
Areas. As we say in Scotland, you choose a window, you're leaving.
Jeez.
No, I think wrap-up comment is, I think it's been a really interesting discussion. I have learned the most important thing I've learned is this definition of different types of people, because that deal with health issues in this. I mean, I know it intuitively, but I'm very interested in that. Actually, people have separated people into this type, which I think could be very valuable for acting on medical interventions and how we deal with these things, personally speaking. So that's something I'm very very happy to have learned. And also, just I think we're all reading off pretty much the same page, same concerns. We want to get this better. We want to do this better. Yeah.
I would echo that. I think we moved it along a little bit. We've moved the needle a bit further, and we can appreciate the nuances in all of this, and that what's right for one person in some circumstances might not be right for another. But broadly, if you've got a strong family history of cardiovascular disease, heart attacks, brothers and sisters with stents and bypasses, familial hyperlipidemia, all these other things that people kind of know are in their family history, and they just bury their head in the sand and say, oh, that's not going to be me, then there is something you can do to actually know, look under the hood and do the dipstick test and see whether you have got this developing, and then take action in the hope that you can reduce that future event. So I would say I think it's been really useful, and thanks, Ivor, for inviting us on.
Oh, not at all, guys. And I really enjoyed it because I love an argument anyway, as everyone knows. But I've certainly been reminded too, Malcolm. I'd probably become complacent about the shortfalls and shortcomings of the medical industry. So it's been a good reminder for me, and focusing in on exactly that what we're really about is personal responsibility, finding out what's under the hood, should you wish to find out, and take action before you keel over. But that will depend on the individual taking responsibility and thinking about what they're doing, and not just willy-nilly wandering in because it's a new fad. That doesn't really serve so well. So excellent. It's freezing cold in my office here. I'm almost shaking with excitement. But that's great. Really appreciate your time, guys. And I have the other whole chunk of material from when we were chatting the other day on the various different points. So I'll splice them all together into a kind of a Friday night special for people to watch. How's that sound?
Good, Ivor.
Thanks very much.
Great stuff.
Steve,
Thanks, guys.
bye. Take care.
Later.
Bye-bye.